Okay, good afternoon, everyone. I'm Channa Hevamaddam. I'm neuromuscular neurologist from Sheffield, and I'm going to chair this webinar today. This is two-part webinar. In the first part, we'll be exploring how exercise and fatigue in myasthenia gravis is managed, and how we assess fatigue, and how we could then use that knowledge in advising patients on exercise. And second part is about how do we organize myasthenia gravis multidisciplinary teams and support patient care across our region. So, so the next slide, please. So this webinar is one of three, and this is the third one out of a series of three webinars, and very kindly sponsored by Argonex. And thank you to them. Next slide, please. So this is our panelists in the first half of the webinar, where we'll be discussing about exercise and fatigue. It will be I'll be joined by Dr. Maria Elena Farrugia from Glasgow, along with her specialist nurse Caroline Carmichael. And then after that, for the second half, which is a sponsored symposium, again, our panelists would be Sue Thomas and Dr. Priya Shamgaraja from Leeds, Lisa Katsi, and Gio D. Guzman, a specialist nurse, will be joining us. And the next slide, please. So this is the timeline and our agenda. So from 4 to 4:45, we will have two speakers discussing exercise and fatigue aspects of myasthenia, and then we'll have a question and answer session. Please put your questions in the Q&A, which is in the bottom of your screen, in the bottom part of the ribbon. There is a Q&A, so please use that to post your questions, and please make it interactive. That will make it more useful for all of us. And then we'll have a short break, and then we'll move on to the second half of the webinar, which will focus on building pathways for better patient care through a multidisciplinary team platform. And then the next slide. Yes, and please use the Q&A function at the bottom of your screen to ask your questions. And then at the end of each webinar, we will have a Q&A session where we'll bring your questions up for discussion. Without further ado, let me introduce our first speaker. Is Maria Elena Farrugia. She's a consultant neurologist, and she's a lead for myasthenia and adult muscle services in Glasgow, and she works in the Institute of Neurological Sciences. And together with Maria and several colleagues, we have now updated our ABN guidelines. So she's a very active member in this process as well. So over to you, Maria.
Thank you, Channa, and thank you for the kind invitation for today's webinar. These are my disclosures. So the objectives are as follows. So we are going to discuss how to recognize fatigue in patients with myasthenia and distinguish them from fatigability. I will speak to you about some fatigue scales that are out there, and then Caroline will speak about managing fatigue. So what is fatigue? So we actually have all experienced fatigue from time to time. This is a subjective experience that can range from a little bit of tiredness up to severe exhaustion. And this is very frequent in people who have some kind of viral infection, particularly after influenza. It is a common symptom in neurological patients, not only in myasthenia, but also in multiple sclerosis, and also a symptom commonly experienced by cancer patients in oncology. There are two components of fatigue. So there's the peripheral fatigue component, or the fatigability. This is weakness associated with muscle fatigue and lack of stamina. And we see this also in our genetic myopathies, where there is underlying muscle weakness, and they speak of, muscles shaking and muscles fatiguing, and not being able to push through. In myasthenia, we often find that symptoms are a bit better in the morning, better after a period of rest, and worse with repeated exercise and activity. And of course, this component of fatigability will be receptive to MG-targeted medications, so be it pyridostigmine, be it immunosuppression. In contrast, we have central fatigue. So that is a lack of energy, a feeling of exhaustion that is not related to underlying muscle weakness. In fact, we can see this even in patients who have good muscle strength. But nevertheless, it is a symptom that would interfere with activities of daily living and with function. Every day for these individuals seems the same, and symptoms are not relieved by rest or by sleep. And patients would say that they can often rest or sleep for long periods of time with no change in symptoms. And in this case, we find that any of the MG targeted treatments do not improve symptoms. There's a concept of primary fatigue versus secondary fatigue, but often it is very difficult to dissect one from the other. Myasthenia patients will be vulnerable to developing what we call secondary fatigue, and that is fatigue developing as a result of other causes. So, for instance, mood changes, and those mood changes could be pre-morbid mood changes or secondary to steroids that we often implement in our management of myasthenia. They could be changes, fatigue due to sleep changes and insomnia. Again, insomnia is often provoked by steroids. It could be fatigue from weight gain, the development of obstructive sleep apnea, fatigue from anxiety, depression, pain, discomfort, and particularly in older patients who may have multiple other comorbidities, they can have quite significant fatigue too. There may be some predisposing factors in making an individual vulnerable to developing fatigue. So in this slide, you will see that there are many factors here that are often interlinked and feeding into each other. So for instance, somebody who may have started off with poor physical fitness and maybe already deconditioned, then developing myasthenia, that of course is going to feed into the fatigue loop. And of course, people with poor fitness may also be obese, may have other comorbidities. There may be sleep, pain, low mood, and there may be psychosocial factors and poor quality of life that are also feeding into these other factors, compounding fatigue. The problem of fatigue in myasthenia is actually quite significant. So the prevalence ranges up to 82%, and it is higher in patients who are symptomatic from their myasthenia. So in the graph on the right-hand side, you will see that fatigue is also present in people who have ocular myasthenia. So it's not just purely because of muscle limb weakness, but also ocular myasthenia will predispose to fatigue. But of course, as we go to the right of the graph, we will see that people who have oculobulbar myasthenia or generalized myasthenia, their fatigue levels are much higher. And you will also see that the people who are, so you will also see that patients who are female are more likely to experience fatigue more than males. So fatigue is worse in more symptomatic patients. It is more prevalent in patients with generalized myasthenia and the more severe myasthenia, and it is worse in female patients. The question I suppose here is, why does fatigue happen? So the signal of muscle weakness that happens when somebody develops myasthenia is communicated to the central nervous system and tells the brain to downregulate physical activities. And in that sense, it is actually protecting the muscles from further damage. And this makes sense, isn't it? That when somebody has active myasthenic symptoms, you don't want them to go to the gym. But of course, what happens is that that feedback loop becomes chronic, so that physical activity is switched off on a longer term basis, and there is central activation failure. And this will result in a chronic negative effect on muscle mass and strength and significant deconditioning. Do we have relevant biomarkers? Yes, we do, because fatigue will have an impact on the central nervous system, on endocrine and immune systems. But unfortunately, these are not biomarkers that can be easily tested. So it's not easily testable to, for instance, test on secondary mitochondrial changes. These are really difficult to identify. And of course, various cytokines are released with different influences on IL-1, IL-6, TNF alpha, interferon gamma, but we don't have the ability to test for these on a regular basis in the lab. So how do we measure fatigue? Fatigue, as you can appreciate, is very abstract. it has multiple aspects to it. There are multiple domains to fatigue. There are several patient-directed questionnaires, and these are often asking the individual about symptoms in the last 1 to 4 weeks. The question is, which is the right scale? Which is the right tool? And I am not sure I have the answer for you in terms of this question. In this slide, this is a summary of all the questionnaires that are available out there. So quite a number of them. And you'll see towards the end of the slide, there is a scale called the Myasthenia Gravis Fatigue Scale, which one would think would be quite relevant in our population. Fortunately, it is very difficult to get hold of. I haven't succeeded as yet. It was published in 2003 in the Journal of Neurosciences Nursing. So let's mention a few of these scales. So the shoulder fatigue scale, or CFQ-11, is a psychometrically sound scale of fatigue, which was investigated in multiple sclerosis. And it is a composite of physical and mental fatigue severity. It started off as a 14-item scale, and then the 11-item version came about after principal component analysis and item discriminative property exercise was carried out based on receiver operating characteristic analysis. And after that exercise, 3 items were eliminated. These 3 were as follows. Do you start things without difficulty but get weak as you go on? Do you think as clearly as usual? And are you still interested in the things you used to do? They have 2 scoring systems for this scale. One is the bimodal score, which is 0 or 1, and then the Likert score, which is 0 to 3. And you will see on the right-hand side of the slide a comparison of usage of the 2 scores. The 11 items pertaining to this scale are very relevant to our population. I have some problem with question number 11, which is, how is your memory? And I think that would be quite difficult for any person to explain or answer in terms of less than usual, no more than usual, more than usual, or much more than usual. So I think that requires a little bit of guidance. The fatigue severity scale was actually originally developed for patients with multiple sclerosis and SLE, but later also applied for patients with stroke. It has 9 items, and a score of 36 or more suggests that there is significant fatigue that needs to be investigated a bit further. The fatigue short form is an 8-item scale. This was derived from the Neuroqual. There's actually also a fatigue short form with 10 items derived from the FACIT fatigue scale, the functional assessment of chronic illness therapy, which has 13 items. I quite like this one. This is the fatigue scale for cognitive and motor function. It actually has 20 items, but all are quite relevant to patients with multiple sclerosis. And there is a combination of, as it says on the label, on the tin, a combination of physical and cognitive questions. So, for instance, number 2, it's a physical question where it is asking about episodes of exhaustion and movements becoming clumsier and less coordinated. Number 4, experiencing episodes of exhaustion incapable of making decisions, so a cognitive component. Number 6 is somewhat psychosocial, episodes of exhaustion leading to the individual becoming less sociable than they used to. Number 12, less motivated than others to start activities that involve physical effort. So that's a bit of a combination of motivation as well as the effort. Number 14, slowness in movements. And then 18, an item which speaks of concentration. And then number 20, speaking about forgetfulness. MFI stands for multidimensional fatigue inventory. It has 20 items. I don't want to dwell on this one. I just want to point out that this is different to the modified fatigue impact score. This was modified from the fatigue impact score, which was based on interviews that took place with patients with MS, looking into how fatigue impacts their activities of daily living. So I would like to spend some time about the modified fatigue impact score, because I think it is very practical in terms of its application to our patient group. So it has three domains. It has physical, cognitive, and psychosocial, with item 8 and 9 um, in terms of relevance to psychosocial domain. Um, and the way it works is there are 21 items. One tallies up the physical subscale, the cognitive subscale, and the psychosocial subscale individually, and then tallies up the total MFIS score altogether. And the range can be from 0 to 84. So this is a scale that we actually used in a study, which is now a bit old. In fact, it was published in 2018, and we had um, called it the physical and cognitive psychological approach to fatigue management in patients with myasthenia. So we took 10 different items over 10 weeks. We recruited 10 patients with stable myasthenia. These were patients who all had significant fatigue. They were on a range of medications for myasthenia, but we did not alter their myasthenia treatment during the 10 weeks of the study. And we tackled different topics, for instance, sleep, pain, lifestyle choices, diet, stress, hobbies, family support. And in this study, there was Caroline looking after patients and asking them different questions. There was a neuromuscular physiotherapist who was showing them very simple exercises, and a neuropsychologist as well. And what we found is that during the study, there was a trend for an improvement in the physical and psychosocial component of fatigue of the MFIS, but there was actually no change in the cognitive component of MFIS. So it stubbornly remained unchanged throughout the study. At the end of the study, we actually we called them back after 3 months and reassessed them and tried to establish whether their MG had changed and also whether their fatigue scores had changed. And what you will see is that although there was a trend for an improvement up to week 10, then there was a return to their almost baseline fatigue scales at the end of the study. We also used the visual analog fatigue scale. So this is really simple. It takes 2 seconds. 0 is your worst level of energy, 10 being normal. And what we found is that during the course of the study at week 10, there was a significant improvement in fatigue levels, and this reached significance. But unfortunately, the fatigue levels then returned back to almost baseline, not quite at the 3-month mark. So in conclusion, fatigue is common in patients with myasthenia gravis, and it is completely distinct from fatigability and weakness, which is inherent to myasthenia. But nevertheless, fatigue is an important symptom in myasthenia. It is important to identify because the trick here is not to escalate immunosuppression. That is not the solution for patients, but it is important to identify the problem and manage it accordingly. I think it is very important to educate patients and caregivers about the concept of fatigue early on, probably at the time of diagnosis, in order to educate them and to help them recognize this symptom as well. We can measure fatigue in the clinic, but I think identifying the right tool remains a challenge. And thank you for listening.
Thank you very much, Maria, for that excellent talk. And as you very correctly highlighted, recognizing the fatigue and to be able to have some sort of a feel for that is when the tools become very useful, so that you don't unnecessarily escalate the therapy in order to bring down the fatigue, but when the myasthenia is under control. But we can discuss this. If you have any questions and examples of challenges that you faced in the clinic, please remember them and put them in the Q&A. So next speaker is Caroline Carmichael, Maria's partner in crime over in Glasgow. She's a specialist nurse in myasthenia gravis, going to speak to us about uh, exercise and how do you advise patients on exercise and manage their questions around this, which is a very important part in myasthenia. So over to you, Caroline.
Just starting up. My name is Caroline Carmichael. I'm the Myasthenia Gravis nurse at the Queen Elizabeth Hospital in Glasgow, and I work with Dr. Farrugia. These are my disclosures. And so the aim of my talk today is really to gain a better appreciation of exercise in myasthenia and gain confidence in advising patients on how to exercise. Also a better understanding of how to advise patients on exercise and reflect on the benefits of using exercise in myasthenia. So first of all, I thought I would start with just maybe highlighting what we know about exercise benefits in other healths. So a little bit of figures and statistics to ponder over and digest. So we can see that there's clear evidence that exercise is beneficial in other health conditions, but we don't have a lot of evidence out there directly related to myasthenia, so we just kind of extrapolate from what we know of other conditions. So what we know is that many adults spend more than 7 hours a day sitting down, and this is between a combination of work or on transport or in leisure time. And people over the age of 65 spend greater than 10 hours or more sitting down or lying down. So this in itself makes them the most sedentary age group. Now, the old school thoughts on myasthenia and exercise was basically avoid. There was this sort of understanding or thought process that exercise can exacerbate myasthenia symptoms and increase muscle weakness and fatigue. And often, as we've just heard, patients will often state that they are too tired for everyday tasks and therefore too tired to do any exercise. And this was a sort of concept that ran with myasthenia for quite some time, is that exercise was a negative thing in myasthenia and shouldn't really be embarked upon. However, we know that myasthenia does encourage a sort of sedentary lifestyle, and equally having a sedentary lifestyle will also then add to increase weakness in all muscle groups. And these weaker muscles will also fatigue quicker. So we've got this cycle of fatigue and weakness that comes along with myasthenia as well. But there is evidence also to suggest that carefully prescribed and structured exercise programs can improve aerobic exercise capacity and muscle strength. And this then maintains mobility, increases bone strength, and low impact exercises can reduce fatigue. So why would we advise somebody to exercise in myasthenia? Well, essentially it's to help regain their previous functional level, but also it can minimize secondary complications such as heart disease, obesity, osteoporosis, falls risks, and of course their mental health. And all of these additional complications do complicate myasthenia, so we're looking to try and regain the best we can for these patients. However, there are considerations. Four specific considerations for patients is the time. Many patients will be at their best earlier in the day, and they need to consider when they're going to introduce exercise into their daily routine. The type of exercise that they look to do is particularly relevant to the individual. We need to consider their age and what their expectations would be with regards to exercise. Obviously, the duration of exercise as well, not to overdo it to the point of exhaustion, and the environment being appropriate to the individual and the exercise, so things like the temperature and the heat and things that would influence their ability to exercise. That's not the Beatles, but yeah, just a visual. So where to start in the journey of myasthenia? Well, our experience is that starting as early as possible from the diagnosis is always best for people with myasthenia. Obviously, if they're in an acute myasthenic crisis, we're not looking to exercise, or particularly weak from their myasthenia symptoms, we're not looking to introduce exercise. But as early as they possibly can, once their medication has started to take control of their symptoms, we would encourage starting to introduce some exercise at that stage. Now, we need to consider the baseline abilities of an individual. So what were their exercise capabilities before myasthenia onset, and looking to bear that in consideration when thinking about how they will benefit from exercise. Obviously, there are other things like health conditions. Pre-existing health conditions will influence what ability they have to exercise. And very simple things like motivation and expectations, we have to be realistic. Patients themselves have to be realistic. I had a gentleman ask me after his diagnosis recently, would you be able to climb a Monroe? And I was quite enthusiastic and said, well, once we get you better, we would hope that you could. He's never climbed a Monroe in his life. He's always wanted to be able to do it, and he was testing me a little as to whether he would just get so much stronger that he would be able to climb a Monroe. So we have to be kind of reasonable in considering their expectations and their motivation. And also we need to think about things like the availability and accessibility of facilities for patients, because they need to be able to get to places that are suitable for exercise for them. And more importantly than anything, there's the enjoyment factor. Patients need to enjoy the idea of going to exercise and the benefit that they get from that. So what we know about muscle strength and exercise is that muscle strength does decline as you get older. And from the age of about 40, strength, endurance, balance, bone density and flexibility all decline. And as a result, muscle power is also lost at a faster rate. So doing muscle strengthening activities slows that natural decline in muscle strength and bone density. So how to progress with exercise and myasthenia? So I often will advise patients to start first with gentle range of movement exercises and focus on core strength with a very light resistance work, building up to gentle walks at a very slow pace, and things like swimming, which is gentle on the joints, helps cardiovascular and stamina, and also activities like yoga, Pilates and Tai Chi are very beneficial in the exercise for myasthenia. Activities like sitting to stand, where even the most sedentary people can do that throughout their day, sitting from their seated position and just making some conscious effort to do sit to stand activities, balance activities like yoga, and eventually some weight training activities, gentle lifting of weights. But patients can be very fearful of this because they understand that myasthenia is a muscle weakening condition, and they read about the extreme muscle weakness. So they can be very, very anxious about introducing anything that has weight-bearing elements to it. We do have to remind patients, obviously, to be aware and listen to their bodies. So to stop any physical activity before their muscles fatigue, but also to vary the activity as well. And I think that's the same for anybody that's doing any exercise. It's much more engaging if you vary your activity more. And pacing your activities as well, to reduce the difference between a good and a bad day with a little bit of pacing. The exercises we generally say would be 20 to 30 minutes of stretching exercises, and they can start very simple, initially with seated exercises, stretching out the neck, arms, shoulders, hands, feet, and then up to standing, where they march on the spot and do further stretches in standing positions. And along with any exercises, I also encourage patients to do some deep breathing and relaxations. With regards to exercise, for any type of activity to be beneficial, we need to think about what it does in your body. So moving quick enough that it raises your heart rate, that a person breathes a little bit faster, and that they start to feel a little bit warmer. So when you're considering exercise, that's the type of things that we're looking to have an effect on. So try to include walking in daily routine and split up the activity throughout the day with the low impact exercises, as I mentioned before. Now, I've mentioned about pacing. And what is pacing? Well, pacing is a way of increasing the activity level without exacerbating fatigue too much. And we've already heard a lot about fatigue today. So the aim is to maintain an even level of activity throughout the day, instead of doing as much as possible in the morning and then having to rest all afternoon and evening. So avoiding that boom-bust scenario where a person will put so much energy into doing what they think they need to do first thing and then have nothing left for the rest of the day. So what I advise patients is, if you're feeling fit and strong one day, don't be tempted to overdo things. Try and reserve some energy for the fun stuff as well. Evidence does suggest that in selected cases, exercise therapy is just as effective as medical treatment, or even adds to its effect. But still, there is a need to define the most optimal type and dose of exercise. And as a society in general, we need to support a physical active lifestyle. In order to enhance the physical active level of our population, accessibility is important. So the ideal situation from my perspective with regards to exercise would be individual patient-specific programs that are devised with a neurophysiotherapist who understands myasthenia and also is available for follow-up. And I think in order for patients to really appreciate exercise and to get it embraced in it, many of them do need sort of very targeted and specific programs. But of course, the reality is that we don't have these services that are available to individualize for every patient. Also, access to specific services such as gyms, health clubs, and things that patients themselves want to choose. But I think the most ideal situation is that patients are not fearful of exercising in myasthenia. And then I was wanting to just talk a little bit about a case study highlighting sort of exercise in myasthenia with one of our patients. So this was a 23-year-old female who was diagnosed with primarily oculobulbar symptoms in 2021. So she had nasal speech with mild chewing and swallowing fatigability, although she never required an NG tube. She did have some mild ptosis and blurred vision. She went on to have a thymectomy in March 22, and this showed thymic hyperplasia. So she was treated with pyridostigmine and prednisolone built up to 30 milligrams daily. Eventually, she ended up going on to mycophenolate mofetil as she was unable to reduce her steroid dose down significantly. And her MGA, her myasthenia improved to a point of her MGFA of 1. Before she, excuse me, sorry, back a page. Prior to her myasthenia, she was very active and she used to go to the gym 2 to 3 sessions per week and went out socialising with friends, went to music concerts and such things that young girls do. However, everything stopped when she was diagnosed with myasthenia, and for 2 years afterwards, she really didn't do anything in terms of exercise. She gained 4 stone in weight, contributed somewhat by her steroid use. Her mood was very low and she became very self-conscious about her appearance. She felt she couldn't exercise. She was extremely fatigued all of the time, which we've obviously heard a fair bit about today. And she just felt that with this fatigue, she could never picture herself going into a gym. She worked full time and she did well in continuing to work, but she had a very sedentary job and worked in administration. So she sat at a desk for most of the day. And then after days, she came home from work and she did nothing. And she really struggled for quite some time. Sorry, I think my apologies. So what did we do? We spent some time in clinic discussing her concerns and specifically her views on her myasthenia and her views on herself as well. And we looked at introducing small levels of exercise. So she started to join her mum and walking the dog in the evening, and she felt a certain amount of security of that with having somebody with her if she was to take unwell. She then gradually started seeing some of her friends again. She'd become very isolated, and so she gradually started seeing her friends again and started going for walks with her mum in the evening. And over the period of a year, and it did take quite some time, she built up her exercise to longer walks. She started going back to the gym, doing very small stretching exercise classes, nothing at the level that she had been pre-myasthenic, but certainly had started introducing exercise again, and she was going for walks in the town with her friends. And she was keeping me very much updated on how this was going for her because she was very anxious and nervous about doing exercise in the context of myasthenia. And ultimately, she reflects back now on her myasthenia and she slowly recognised that fatigue and not fatigability was her perception of myasthenia symptoms. She believed that if she was exercising, she would get worse. And she knew that in part her body image perception affected her motivation for her exercise. She had gained so much weight. She said to me that she could never picture herself walking into a gym with so much change in her body shape and size, and she felt very self-conscious about this. But she knew she had to change her way of thinking on exercising, and she remembers that it was something she previously enjoyed and ultimately realised that it would not harm her. So my take from this is that exercise in itself is medicine. So I'm happy to take any questions.
Thank you, Caroline. That was a very practical talk. There are a number of questions that we have received regarding exercises. So we have a question from Emma Manchester. Emma is from Leeds, and she wants to know why are stretching exercises more important or important?
I think it's one of the most sort of lower level exercises to start off with. And getting the body ready for any sort of more intense exercise. If for anybody that does do exercise or any sports activity, stretching is a key element of that. So you're almost prepping the body then to become familiar with then something a little bit heavier. So stretching exercises would always be the sort of starting point, I think, and stretching out the muscles, getting it prepared for anything else.
Yes, thank you. And do you? I think you alluded to this in your talk, that the 3Ps approach to managing fatigue and exercise, the planning, prioritization, and pacing that you alluded to. Do you do you discuss with the patient and the MDT about the patient's myasthenia gravis disease status, the severity, as it were, and any time that you advise to avoid exercises in myasthenia?
From my perspective, yeah, I would certainly avoid exercise when their myasthenia symptoms are acutely active. So, you know, I would probably like to advise on exercise once their medication has started to become effective, and then they can start introducing an exercise regime.
Yes, particularly in those patients who have acute and then also severe myasthenic symptoms.
Sure. Although I've had a patient recently who was in with very significant bulbar symptoms and you know, requiring a lot of medication and help, and he would sit in his bed throwing the ball off the wall, just doing some exercises, even though he was, you know, quite acutely affected. But yeah, I mean, I think if their myasthenia symptoms are significant, you know, you'd want to wait for their medication to be, you know, effective before stepping into the exercise regime.
Thank you. Let me look for any more questions. There's a question for Maria. So clearly fatigue and fatigability could sometimes be even confusing for clinicians to differentiate when you're consulting a patient, and when patient is telling you that, you know, that they're feeling exhausted, and they use words like exhausted and I'm tired, my muscles are spent. In that situation, what tricks do you have in your toolbox to navigate and tease out what might be more fatigue, but not really fatigability? I know it's not straightforward, but it will be helpful to hear your strategy.
I think it's back to basics, isn't it? Largely history taking, listening to their symptoms. Because when they're speaking of, you know, my muscles are done, my muscles are spent, it's often a case where, you know, what they're speaking of is fatigue rather than fatigability. It's also a combination of history taking, the words used, trying to figure out, is this a constant feeling or is there a variation? And then examination as well. Can you actually elicit the fatigability of myasthenia on examination as well? So I think it's a combination of history and clinical findings.
Yeah, absolutely. And if patients use the words such as I don't feel like doing something, I don't feel like I have the energy to do something, that probably indicates a lack of initiation or motivation.
Yeah.
Probably will make you consider that there is what we try to call as cognitive fatigue or central fatigue, as opposed to peripheral fatigue. Do you see that in some patients, even their myasthenic symptoms are well controlled with drugs, but they still complain of fatigue.
Absolutely. Yeah.
Yeah.
Yes, definitely. So it's not necessarily the people who are more symptomatic, but you have people who are either in pharmacological remission or minimal manifestations, and they would be bitterly complaining of symptoms that are in keeping with fatigue rather than fatigability. Um, I mean, the other aspect to this is, for your previous point, is the fact that, rest does not usually do anything for people with fatigue. So these are typically individuals that would spend, many, many hours during the day, where they're resting, and yet that symptom of fatigue is permanent, it's constant, it's not altered by periods of rest. So I think that is also an important distinguishing feature from the fatigability that you would expect with myasthenia.
Thank you, Maria. Caroline, I wondered whether I could ask you this question. In your practice, when have you come across patients whose overwhelming symptom is fatigue? Now, you shared us with a case where you managed to tease that out, and it was not fatigability, but she called her symptoms were largely fatigue. Where when the patient is very fatigued and complaining of fatigue-related symptoms, how do you then advise those patients to take up on exercise when they have already started telling you that they don't have energy, they don't feel like doing anything, because firstly they worry about worsening their myasthenia, and secondly they say that they don't have the energy. How do you navigate that situation?
Yeah, it is difficult, and we do see it a lot. We do see, where fatigue is the biggest problem. I think making them or helping them to understand, first of all, that difference between fatigue and fatigability, and letting them understand that you appreciate what they're talking about in terms of fatigue, and then just gradually going through other aspects that maybe are making them fatigue too. So, like with this young girl that I spoke of, I think her sort of social isolation had really pushed her back in progressing. So looking at things that may also be influencing, like mood, body image, social isolation, and trying to kind of address each of these things individually, that can help with them getting a bit more motivated then to do some exercise. A lot of our patients do become deconditioned then through a period of time from maybe when their myasthenia is very acute, they're in a position that they're not able to exercise because of how acute their myasthenia is, but they become quite settled in that sort of pattern, and helping them understand that when myasthenia was very bad and they weren't able to exercise, but things are different now, and the best thing for them that fatigue can be helped with exercise, although it sounds counterproductive, but helping them to understand that actually exercising in fatigue is a good thing, even though we appreciate that they don't have or they feel they don't have the strength or the energy to do anything. So even just starting really slow and saying, look, how about if you just try to walk to the end of the garden and back in the morning and then the evening, and see how you get on with that, and then let's build that up again the next day. And so it's mostly it's graded stuff as well, so for them to feel the effect as well and be motivated by the changes that they can see.
Yeah, that's very helpful advice. And there is a question about what extent do you go to personalize the exercise program? Do you get involved with that, or do you ask your physiotherapy colleagues to how do you manage
Yeah.
those
I mean,
situations?
that is, as I said at the end, that's my ideal. I want a physiotherapist to devise a program for every person that has myasthenia, and that's not, we know that's not practically possible, but I think personalize it as much as I do, like advise as much as I can from knowing my patients and knowing what their baseline would be. And so an elderly gentleman who used to enjoy a walk around the park, right, that's where we're going to go to. We're going to try and get you back to walking around the park. A young girl who climbs mountains, right, let's see if we can build you up to getting to do your first climb again. And so, yeah, I mean, you have to bear in mind what these individuals' lives are and what their normal status would be. But realistic as well, because with the passage of time, if somebody's had a sedentary myasthenia state for a long period of time with no exercise, and you're looking at 10 years down the line, we're not going to get them back to where they were 10 years previous either.
This question is for Caroline or Maria. When it comes to exercising, what is your take on the aerobic exercises versus strength training exercises? Do you have a preference? Is it, people might wonder whether is it safe to do, for example, strength training, weightlifting type of exercises? Do you have a take on that?
Maria, do you want me
You go.
I think it depends on the individual as well. Again, what their preference of exercise is. Obviously, if they've had some limb involvement, weakness with their myasthenia, they want to build that up very slowly. I think weight exercise is helpful, but it has to be a very gradual sort of process. And building up, I think for the whole exercise thing, it has to be done slowly and built up. So to think about going into the gym on the day you get out of hospital or the day after you get out of hospital with your myasthenia and start pumping iron, I think is fairly unreasonable.
Yes, I think that there is, in terms of people wondering whether to advise or not on someone with myasthenia on exercise, what the evidence so far from, although these studies are limited and small numbers, is that mild to moderate myasthenia gravis is considered safe to do both aerobic and strength training exercises. There is a question about much of fatigue appears to be related to steroids and their side effects. Does this understanding influence your thresholds to bring down steroid dose and introduce steroid-sparing agents? Maria, it sounds quite obvious, but what is your take on it? Is it not easy to bring down steroids very quickly for a big proportion of patients?
Yeah. Yes. So there are two aspects to it, isn't it? That steroids are great in terms of improving myasthenia symptoms, but they are so much associated with so many side effects. So I think it's a balance of realizing at which point you are winning with myasthenia, but if you continue to persevere at that dose, you are just going to compound the treatment burden with steroids. And I think we all have to be very mindful of the repercussions of high dose steroids. So even when you observe their breathing pattern really changes significantly when they have been on high dose steroids. And that has a deleterious effect on a lot of other things, the way the breathing pattern goes, and then that is going to impact as well their energy levels, their well-being, their anxiety levels. So I would advise always a balance of treating appropriately for an appropriate time, but then inching back slowly when you think the time is right in order to reduce the steroid burden.
Yes, I do agree with you, and that's partly why we need fast-acting, highly efficient drugs so that we can bring down the steroids before they cause burden to the patient. There was another question about. No, I think we have answered all those questions. I have a question to Caroline. Caroline, sometimes fatigue and feeling lack of motivation or initiation could be a feature of low mood. Have you come across situations where the low mood or depression is subclinical, but that's what's driving? Because myasthenia can be incredibly isolating, and it can take you away from what you're enjoying, your job, hobbies, etc. Can have a significant impact on mental health. It has been shown that 40 to 50% of the people can have low mood or depression in myasthenia. Do you how do you approach to explore depression or low mood or anxiety in this cohort of patients?
Yeah, we do see it a lot. Myasthenia can significantly change somebody's lifestyle and how they sort of picture things. So, that does have a big effect on their mood. We can use the hospital anxiety and depression scale, the HAD scale, to assess the sort of severity of anxiety and depression. But certainly that does influence things like their motivation for exercise. And if necessary, you know, they can get them on some treatment for their mood. And quite often, a small amount of treatment can help them enough to then engage with getting into an exercise program and managing their fatigue better. Sometimes it's difficult to know what predates. You know, some people can sit with a low mood that doesn't necessarily impact them, but then with the diagnosis of myasthenia can sometimes push them over the edge then and need that little bit of extra help. So if you know if there is an indication of low mood, it's best to kind of get on that quite quickly, because lack of motivation, it has a lot of impact on other things as well, you know, things like adherence with medication, as well as exercise and fatigue.
Thanks, Caroline. We have time for one last question. If I may ask this from Maria, I tend to regularly monitor fatigue using Neurocall short form. It's not quite constructively or psychometrically. There are some question items which are not truly representative of myasthenia, but I find that quite helpful. And Regain study where they use eculizumab use Neurocall and showed that fatigue also resolved or improved with treatment. My question to you is about sometimes as busy clinicians, you might not have the time in your clinic to do all these scales. If you were to use a scale, what is your preferred scale, and in what sort of clinical scenario do you recommend objectively assessing fatigue in a patient? I can only think of when the express fatigue symptoms are really interfering your management, so you do not know at some point whether to escalate the treatment. Is this patient referring to really physical fatigue, or is there some sort of a cognitive fatigue? There are two questions, if you don't mind.
Yeah, so I think the modified impact score is good because it breaks down the domains. That's my preference. But then the fatigue scale for cognition and cognitive and motor function is also a good one, I think. It's got 20 items. The other one has 21 items. I quite like the breakdown of the cognitive and the motor aspects. And you could also tease out the psychosocial aspects in there as well. You're right, clinics are busy. And by the time you have examined them, perhaps done an MGADL, you know, there's probably not very much time to go through a fatigue scale as well. I think it's the time when it is appropriate to actually document fatigue is actually when perhaps you have this disparity or argument between yourself and the patient, where you think it is more fatigue and the patient thinks it's more active myasthenia and that treatment should be escalated. And I think sometimes showing them objectively what's going on is quite useful. I had someone where it happened a little bit in the reverse, where it was actually the MGADL score, not the fatigue score. But actually, when you take a history from her, she is reporting really symptoms of fatigue. But then when you do the MGADL, that actually does not necessarily reflect her examination. So I think sometimes having these scales on paper can be quite helpful for the patient when you're actually trying to explain to them why you think it is myasthenia or why it is fatigue, and explaining the rationale for your management for that particular patient.
Absolutely. It works as a biofeedback, doesn't it? And
Yes.
then also sometimes I find it very helpful a few months later, and then they feel that their fatigue is still a problem, but when they score it, it has really improved.
Yes,
And then it's about the perception of your fatigue as well, to some extent. Yes.
absolutely.
Well, thank you so much. It's such an engaging discussion, Maria and Caroline Carmichael. This is really helpful. I found it very helpful. I'm sure our audience, I noticed that there was this number of physiotherapy colleagues on here. So I'm sure there was some bits for everyone to take home. Thank you so much for joining us.
Thank you for inviting us.
Yeah,
Thank you.